Hi, I'm Hirotoshi Ishiwatari from Shizuoka Cancer Center in Japan. I'm honored to have this opportunity to talk about our article published in GI. The title is Optimal Number of Needle Passes in Endoscopic Ultrasound Guided Tissue Sampling for Genomic Profiling, a randomized non-comparative trial. We've been working on this topic for over 5 years, ever since commercial comprehensive genomic profiling (CGP) test became available in Japan in 2019. So I'm really excited to share our result with you today. The cool thing about this study is that it shows how to collect sample for successful CGP test in a prospective study, which has not been done before. As you know, matched therapy based on CGP test can have a huge impact on patient prognosis. Several studies have shown its survival benefits. So it's important to make sure patients have the chance to receive it. Depending on the country, the timing of CGP test varies, but ideally it should be done either at diagnosis or before the completion of the standard treatment. In pancreatic cancer, drug options are limited. There's only a few first-line treatment considered standard, and there's basically no established treatment once those fail. That means the tissue sample collected at diagnosis often ends up being the one used for CGP testing. So it's critical to collect enough tissue suitable for CGP testing during the first US guided biopsy. Otherwise, we might miss the chance to retest later. This is because pancreatic cancer can worsen symptoms within a short period of time, and the first-line treatment may reduce the patient's quality of life, making it hard to do another biopsy. So, collecting good sample the first time is really important. That said, CGP testing requires more tissue than a standard pathological diagnosis. For example, the Foundation 1 CDX, F1 CDX, a widely used commercially available CGP, needs 10 unstained slides from a single FFP block, each with at least 25 square millimeters of tissue. To meet this requirement, we used a method called combined embedding, where we make a single FFP block from all the tissue collected during US guided biopsy. In our previous study, this method significantly improved the success rate of F1 CDX compared to traditional non-combined embedding. So we applied it to all patients in this study. Another important point from our earlier work is that more needle passes generally lead to higher chances of getting an ideal sample for F1 CDX, at least when using a Franci needle. We found that 4 passes with a 22 gauge needle and 2 passes with a 19 gauge needle might be optimal. Also, most macroscopic on-site evaluation may help reduce the number of needle passes when using a 22 gauge needle, since several randomized controlled trials have already shown its usefulness in pathology sampling. Based on all this, we designed a randomized non-comparative trial to evaluate whether these 3 methods, 2 passes with a 19 gauge needle, 4 passes with a 22 gauge needle, and most with a 22 gauge needle, could help collect ideal and successful samples for F1 CDX. The study design might seem a little complex at first glance, but it's actually pretty straightforward. Our primary endpoint was the rate of obtaining ideal samples for F1 CDX. We hypothesized that our protocol would achieve a rate of 85%, which is 25% higher than the historical control rate of 60%. With a one-sided alpha of 5% and 80% power, we calculated a sample size of 25 patients per group. We also pre-planned a two-arm comparison as a secondary endpoint. In the end, the study showed that all three methods allowed us to collect ideal samples in over 90% of patients. As for the secondary endpoints, the median number of needle passes in the MOSE group was 2, which was significantly lower than in the 4-pass group. Also, the 4-pass group took more time compared to the other groups and had one case of moderate abdominal bleeding that required transcatheter arterial embolization. In the cases where F1CDX was actually performed, all tests were successful. Taking all of this into account, we believe the best strategies are either using a 19-gauge French needle with 2 passes or using a 22-gauge French needle with MOSE. Thank you once again for listening to my talk. I believe our result will likely improve patients' chances of receiving matched therapy and help reduce the burden on endoscopists by minimizing the number of punctures needed at the target site. We hope our findings contribute to more efficient and patient-friendly genomic testing, especially in pancreatic cancer, where timing and sample quality are so critical. We are continuing our work in this field, and we look forward to sharing more data in the future. Thank you very much.